Well, good morning, everybody. Can everybody hear me okay? I am very happy to be here. Thank you for the invite, Dr. Scott. And I will go over a lot of material very quickly because the purpose I want to accomplish today, hopefully, is to provide you with as much information about the thyroid so that you can do this yourself. So to the extent that I can get all the information that you need, I'll try to do that very quickly, but you have the recording of the sessions, so you can always go back and look at things where I've gone too fast or so. And so let's get to it. All right, so case number 1, I'm going to read, follow along, please, and there will be questions about it. Don't feel obligated to get the right answer. It's okay if you get the wrong answer. It's actually, nobody's going to call you out or anything. It's just an opportunity for you to discover what is the right solution, and you can get there by, a lot of times if you just do the wrong answer, it just stays in your mind. You never forget it after that. So don't feel bad about raising your hand for the wrong answer, okay? So in 2020, I saw this patient, and these are all, by the way, actual patients that many of them were referred by some of you here. MC is a 38-year-old female patient referred by her gynecologist for evaluation of possible Hashimoto's thyroiditis. History includes anxiety on fluoxetine 10 milligrams per day, iron deficiency due to menorrhagia, and allergic rhinitis. No family history of thyroid disease, and the patient has no symptoms. Physical exam revealed goiter, and the gynecologist ordered thyroid labs and thyroid ultrasound. TSH was 1.34. I did not put a range for that on purpose, and we'll talk about that a little bit later. Free T3 was 2.66. TPO antibody elevated at 53. Thyroid ultrasound showed borderline thyroid enlargement, mildly heterogeneous parenchyma, and bilateral cystic colloid nodules. Repeat TSH that I did was 0.98, free T4 1.12, free T3 2.8, all in the normal range. Ferritin was 8.9, which is low, and iron saturation 17%, again low. All right, so we go to the next slide where we have the questions. What do you feel is the best next step in management? And raise your hands for the answer that you feel is right. A, start patient on levothyroxine 25 mcg every day. Anybody thinks that's the right answer? B, start patient on brand name Synthroid 25 mcg. Anybody thinks that's the right answer? C, start patient on liothyronine 5 mcg every day. D, monitoring of thyroid function and symptoms. Okay, several hands, right? And E, order final aspiration biopsy of nodules identified on ultrasound. Okay, so a few hands. And the right answer is D, monitoring of thyroid functions and symptoms. Why? I'm going to explain why each of the other answers is not the right one. So A and B are basically the same thing, whether to start on levothyroxine 25 or Synthroid 25. We'll talk a little bit more in next slides about the difference between brand and generic, but it amounts to the same thing, which is starting the person on thyroid hormone. Now, there is no indication to start because she doesn't have symptoms, and also her thyroid functions are completely within range, so there is no need to start thyroid hormone. T3 starting, again, is the same idea, is that there are no symptoms, thyroid functions are within range. There is a theory out there that I've seen several or some people do, which is to start the patient on T3 if their T3 level is below 3. Now, the range is between 2 and 4.4. We'll talk a little bit more about T3 in coming slides, but there is no support for this theory in practicality. Now, of course, proponents of this theory will say that when you start patients on T3, especially if they are having fatigue or other symptoms, that they would improve, and those symptoms would improve. And maybe that's the case, perhaps, but that might be because of the non-specific action of the T3. It is similar to drinking coffee. When you drink coffee, a lot of you have had that experience today, then you have some non-specific stimulant effect. Right, but that doesn't mean your diagnosis is being decaffeinated. You're just getting this non-specific effect of coffee. Same thing with the T3. It has a non-specific stimulant effect that can, of course, give the patient a boost of energy, but that doesn't mean that their problem is underactive thyroid. And of course, if you treat something that the patient doesn't have, you always risk overshooting and always giving unnecessary medication and producing side effects. So, C is not the right answer. Now, how about E? Now, E is probably the hardest distractor to rule out, and it requires some knowledge of the ultrasound. Why do we do ultrasound for the thyroid? For two reasons. Number one is to identify if the patient has nodules or not. Some of them can be cancerous or malignant. And number two is for the echo texture, to comment on how does the thyroid appear on ultrasound. When it comes to nodules, there are three things on the report of nodules that you could see. One is a simple cyst, or sometimes also called colloid cyst, because the colloid is the material inside of that cyst, the fluid inside of the cyst. Now, a simple cyst, which only has fluid, has zero chance, almost zero chance of being malignant. It is simply a wall with some colloid inside. So you don't need biopsy for that. Cystic nodules or partially cystic nodules, which have some solid component and some fluid component, they have a malignancy potential. Now, it's not high, and the presence of fluid tends to decrease the malignancy potential, but it is existent in the solid part of the nodule. Now, the third category or third answer you can get on the nodule is a solid nodule. And it depends on the appearance of the nodule on the ultrasound, what's the malignancy potential of the nodule. So you could have a nodule that has microcalcifications or irregular borders or hypoechoic texture, several things in it that would basically raise the possibility of that nodule being malignant. The radiologists agreed to having a TI-RADS classification system. What that means is that every suspicious finding on ultrasound gives you a point on that system. And you will see that a lot of times if you order a report of the ultrasound, that if the TI-RADS end up being 4 or less, so 2 or 3, for example, that goes more with a benign potential. And if it is 5 or more, that is more in line with a malignant possibility. Now, again, remember that the possibility of a malignancy in any thyroid nodule you find is 5% or so. So it's important to keep that in mind to reassure the patient that most likely this is going to be benign, but we still might need to do our due diligence and order a biopsy. Not in this patient. This patient has colloid nodules, so the potential for malignancy is almost nil in these nodules. But the second And by the way, at the time of questions, I intend to leave a lot of time for questions. We could, if somebody wants to ask me about the process of the fine needle aspiration biopsy, be glad to answer that. The second reason that we order an ultrasound is to comment on the texture of the thyroid. So a gland that has autoimmune thyroid disease will typically appear heterogeneous on the ultrasound, which is exactly what you found here. Now, what that means is that there is an inflammation going on inside of the thyroid, and that resulted in the appearance becoming heterogeneous. Sometimes it's even associated with what we call pseudonodules. These are not true nodules, but they are pieces of hypoechoic tissue, like Swiss cheese almost, that can appear on the ultrasound and sometimes disappears on subsequent ultrasound measurements, which can confuse patients and sometimes us as physicians a lot. The patient would say, well, I know that they told me I had a nodule, and now they did an ultrasound, they said no nodule. Well, sometimes that happens with Hashimoto because those were not true nodules. They were created by the scar tissue around the hypoechoic texture of the thyroid, giving the false appearance of a nodule. Okay, so in this case, we got the ultrasound saying heterogeneous echo texture, but we do not need a biopsy. So this is a case of Hashimoto's thyroiditis. However, Hashimoto's thyroiditis does not mean hypothyroidism. These are two different things. One of the things that I would like to share with you, and I hope that you already received that in the email, is lots of handouts that were emailed to you that feel free to share them with patients. I do. I keep a lot of them in the drawers, and I give them to patients as I see them because the time of the visit is short. Patients are always curious about what's going on, so you give them those handouts. They complement the visit and give them education. One of them is what's the difference between Hashimoto's thyroiditis and hypothyroidism. Hashimoto's is the process that happens in the gland. Hypothyroidism is the result of that, of decreased thyroid levels, decreased thyroid production by the thyroid gland. So one can have Hashimoto without having hypothyroidism, like this case. Sometimes one can have hypothyroidism without having Hashimoto. They can have underactive thyroid for other reasons other than Hashimoto's thyroiditis, although Hashimoto tends to be the most common reason for the hypothyroidism. So on the next slide, I would like to show you the physical exam. Now, of course, kudos to the doctor, to the gynecologist who did that exam and found the nodule, the firm echotexture on the thyroid consistent with Hashimoto, the goiter that made her order the ultrasound, get the lab work, and do that. And I want all of you to be familiar with how to do the exam. In this picture, you'll see the difference between a normal thyroid levels, thyroid appearance, and between the appearance of the thyroid in Hashimoto's thyroiditis. As you can see in Hashimoto, the thyroid gland tends to be enlarged, at least at first. Later on, by the way, in advanced stages, can actually shrink from the fibrosis that happens in the gland and can end up being very small in size. But in the early stages, you can feel it enlarged. It has a specific appearance to it, a specific feel to it. If you examine a lot of thyroids, which I encourage all of you to do, you will feel the normal thyroid very soft. You cannot feel any enlargement or any firmness. On the other hand, when you do the exam for Hashimoto, you will feel this is firm, bumpy, irregular, and usually one side is slightly bigger than the other. Now, how to do the physical exam for the thyroid, I think this is important to know because I want all of you to know that. The best way to do it is from behind the patient, where you put your thumb on the occipital bone on either side. When you're examining with one hand, you're simply pushing gently the trachea, isolating one lobe so that you can feel one lobe with your two fingers, the index and middle finger. You ask the patient to swallow. We'll see in a second why that helps you feel the thyroid. And then you do the opposite. You push the trachea to the other side, or very gently, not hard, just to isolate the left lobe. And then you feel again with your index and middle finger and ask the patient to swallow. You're not moving your fingers. You see, you're putting your finger where the place of the thyroid is, and you let the patient swallow. And as the patient swallows, the thyroid comes up in the neck. Why does the thyroid come up in the neck? It's because it's enveloped in something called pretracheal fascia. And as you swallow, the trachea moves upward, and everything that's involved in that pretracheal fascia moves up as well, including the thyroid gland. Why does the trachea go up when you swallow? Because the larynx has to go up when you swallow. Why does that happen? Because your body knows to close up the airway when you are swallowing so that the food goes to the esophagus, not to the breathing tube. So the larynx goes up, vocal cords close completely the opening of the larynx so that the food would go behind it to the esophagus. So thyroid and everything related will go up as you swallow. Next, we talked about anatomy. Let's talk a little bit about physiology. And what you can see here is from the pituitary gland, which is in the base of the brain, there is a production of the hormone called TSH, extremely important hormone that stimulates the thyroid gland to produce the thyroid free T4 and T3. Why do they call them T4 and T3? The name is very much linked to the iodine content. The thyroid gland uses iodine very avidly. It's the one part of the body, one gland in the body that utilizes iodine extremely much, and that is a property that we use in things like radioactive iodine treatment and so forth. T4 is simply a protein moiety, protein body with 4 molecules of iodine. The way I explain it to patients, it's like a car. You have a car that has a chassis and 4 wheels. Same thing with the T4, thyroid hormone, main product of the human thyroid gland. It is a protein body and 4 molecules of iodine. There is another form of thyroid hormone called T3, which is a protein body and 3 molecules of iodine in special positions. And this T3 is a human thyroid hormone that is more active than even T4. We'll see how that works in next slides. In humans, 80% of the thyroid hormone is in the form, or 80 to 90% of the thyroid hormone produced by your gland is in the form of T4, and about 10 to 20% is in the form of T3. But most of the T3 is actually produced locally or systemically by activation of T4 into T3. So T4, which is the more stable form, prohormone, if you will, present in the blood, circulates, goes to the liver, among other organs, and in the liver it is activated to T3. How does the body do that activation? It removes iodine in one specific spot, one specific location, to make the T4 become T3. A lot of T3 is also produced locally in the tissue, target tissue itself. Then that T3 goes into the nucleus, works on the nuclear receptors. It is the T3 that works on the nuclear receptors, not the T4. T4 is more of a pre-hormone. So now we know what are the products of the thyroid, and those T4 and T3 basically go back in a feedback loop to tell the pituitary gland, oh, we have enough T4, T3, don't produce any more TSH. So that's how the feedback loop works. Let's take a closer look at the thyroid gland. In the thyroid gland, you'll start to see some names that I'm sure are familiar to you, like, for example, thyroid peroxidase. That's thyroid peroxidase enzyme is the enzyme that incorporates iodine into the protein moiety. Thyroglobulin, what is thyroglobulin? Thyroglobulin is a swimming pool in which are the molecules of T4, T3, T1, T2, any combination of protein and iodine molecules, you'll find it in the thyroglobulin. Out of that swimming pool, if you will, comes out the thyroid hormone and is being excreted after that. All right, accordingly, because of that, this is where we get to some clinical aspect of it. You can see that I did 3 arrows. Those 3 arrows are the places where you can find antibodies. Those are antibodies that you test for and see. One of them is the TSH receptor antibody, the one in the middle. It basically, I just placed it in the middle because there is no way to put in that arrow over the entire thyroid gland. What I mean is that TSH effect on the thyroid is important for every single aspect of the thyroid function. And it's the key that unlocks the door, basically. It is what stimulates the function of thyroid gland in its entirety. So TSH receptor antibodies are extremely important. We'll talk about them in the next slide. Then you get the thyroid peroxidase antibody against the thyroid peroxidase, and then you get the thyroglobulin antibody. Now, these antibodies are not created equal. They have different significance and different relevance, as we will see in this slide. So I want to simplify. If you want, by the way, this presentation, be glad to email it to you. Just email me and I'll send it to you. And you'll also have the talk recorded so that you can see it again. But let's start with the least relevant one, thyroglobulin antibody. Now, why do I say least relevant? Because that thyroglobulin antibody is present naturally in 20% of the population. Of course, tends to be present more in patients who have family history of thyroid disease, of autoimmune thyroid disease, but can be present in somebody who doesn't have any family history or any issue with the thyroid. The only effect of it basically is that it can interfere with the assessment of thyroglobulin, which we utilize as a tumor marker for thyroid. Okay, now thyroid peroxidase, that's a little bit more relevant. Now, even though the thyroid peroxidase antibody is highly correlated with autoimmune thyroid disease, it is not pathogenic. And this is an important concept to understand. What do I mean not pathogenic? I mean that if you get thyroid peroxidase antibody in a syringe and just inject it in the thyroid or pour it on the thyroid, nothing happens. It doesn't cause the thyroid to become underactive in and of itself. And that explains why this patient, for example, even though she had a positive thyroid peroxidase antibody, she did not have hypothyroidism. Not everybody who has a positive thyroid peroxidase antibody has hypothyroidism. And that's a point that confuses a lot of patients, and they get very worried on the titer of the antibody or how high the antibody is. That antibody, I liken it when I explain it to the patient as smoke to a fire. When you have a fire, you will have a smoke. The smoke indicates that there is something going on in the thyroid, but it doesn't tell you how much damage is produced in the thyroid gland or to what extent, or whether the person needs thyroid hormone. As I said, it's correlated with autoimmune thyroid disease. What that means is that if somebody has positive thyroid peroxidase antibody, even if their thyroid levels are good now, they have a chance of becoming hypothyroid much more than somebody who doesn't have that antibody. So it's to the tune of about 5% per year, you will pass from normal thyroid to hypothyroidism if you have the TPO antibody. Again, it's 5%, so 95% of the time, you might have the antibody and not progress to hypothyroidism every year, okay? Now, the third one is the TSH receptor antibody. That TSH receptor antibody comes in 3 forms. One, the most famous one, is the stimulating type. The stimulating type is called also, nickname TSI, thyroid stimulating immunoglobulin. And that's the one that is very pathogenic because it works on the thyroid and produces overactive thyroid. So it's the one responsible for the hyperthyroidism in patients with Graves' disease. There is a TSH receptor blocking antibody, and unfortunately that one cannot be measured. Like, there is no commercial assay to measure it. You can measure the general TSH receptor antibody. You can measure the TSI in a lab, but you cannot measure the TSH receptor blocking antibody, or the third member of the group, TSH receptor neutral antibody. So the effect of them, the TSH receptor blocking antibody, you can see it in some of the patients that are very frustrating to treat, and it's more frustrating for them, of course, because their thyroid levels tend to fluctuate between hyperthyroidism and hypothyroidism because of the presence of those antibodies. Sometimes they produce the TSI and it takes over, making them hyperthyroid. Sometimes they produce the TSH receptor blocking antibody, which makes them hypothyroid, and it becomes very difficult to normalize their thyroid functions. But everything has a solution, so we can talk about it in the question and answer section if you're interested. I don't want to get too deep into the kind of immunology and pathology of this. All I want you to know from this table is type 4 hypersensitivity reaction is where you have a cell-mediated immunity. Means that T lymphocytes are causing inflammation and attacking the thyroid gland. All right? That's what happened in Hashimoto's thyroiditis. Again, in Hashimoto's thyroiditis, what's causing the thyroid levels to drop is not the TPO antibodies. I keep repeating this because I know that this is a confusing thing for a lot of patients. What causes the actual drop in thyroid levels is the cell-mediated immunity with activated T lymphocytes that cause the damage to the gland. Type 5 autoimmunity or hypersensitivity is what happens in Graves' disease, where you get the TSI antibody stimulating the thyroid gland. So Graves' disease and Hashimoto, we a lot of times think of them as the polar opposites, but not exactly. In Graves' disease, the pathogenic effect comes from the TSI antibody. There's an antibody that stimulates the thyroid to work more, but in the Hashimoto, it is actually cell-mediated immunity. It's the T lymphocyte. Okay, so what ended up happening in this patient? I know I gave you a lot of theory, but this is just to lay the ground and put in the foundation for what we're going to discuss. Don't worry, from now on, everything's going to be clinical, all right? So what happened with this patient? So because the patient has Hashimoto but not hypothyroidism, I did not start her on thyroid hormone. We monitored her thyroid functions. Thyroid functions remained completely normal. And the most recent results from December 2025, her TSH is still in the normal range, free T4, free T3 normal, and even her TPO antibody has come down to 12. Now, I don't typically follow the TPO antibody. When I check it, I usually check it just to confirm the diagnosis, to know where the patient is, but I do not typically follow it because there is no point, because it's not pathogenic. We know that the patient has autoimmune thyroid disease. There is no point in following it, and it also can become very frustrating for the patient because they can sometimes see the TPO antibody go up and down for no apparent reason. They didn't do anything to make it go up. They didn't do anything to make it go down. There are a lot of theory, I know, especially in the naturopathic world, about things that you can do to lower TPO antibody. And I don't think that is worth the time or effort for patient or you. But anyway, she had iron deficiency, and we treated the iron deficiency. And of course, she didn't have much in terms of symptoms, but iron levels became normal, and the patient was discharged from the endocrinology clinic. I told her, just have your gynecologist check your thyroid function once a year, or if symptoms occur, and that's something you always want to tell your patient. You're following them every 6 months or one every year, but you tell them, here are the symptoms for hyperthyroidism, here are the symptoms of hypothyroidism. Most important for hypothyroidism is tiredness, fatigue, brain fog. Of course, other reasons exist for that, but if some change like that happens, let me know. We can check your thyroid functions right then and there. If you have a problem with palpitations, then let me know also, because that might be overactive thyroid. Okay, so then that's the case. If the patient had fatigue, what would you think is the cause? Would that change your decision to not treat with thyroid hormone? No, it wouldn't. If she did have fatigue, it would be from the iron deficiency, and you treat the iron deficiency, that doesn't change your decision to not give thyroid hormone. Okay, case 2. That I saw the patient in 2024. So his name is NG. He's a 34-year-old male patient working in IT. No previous significant past medical history, with a strong family history, though, of type 2 diabetes, and was admitted to the hospital for DKA, new diagnosis of diabetes. Saw him in the hospital, started long-acting... Oh, I'm sorry. Thank you for noticing. Started him on long-acting, short-acting insulin and metformin, and with time started him on GLP-1 agonist. In this case, we gave him the semaglutide, gradually increasing the dose and tapering off the insulin, as I am giving him a lot of material about the education for nutrition, for physical activity, and so on. He lost 100 pounds and was able to get his A1C under perfect control. There is a point to this backstory. On a follow-up visit, I saw that his TSH was 12.1. Free T4 was normal, 1.5. A1C perfect, 5.3. Okay. He has no symptoms of hypothyroidism. States that he feels great. Okay, but on further questioning, he says he has a history of hypothyroidism in his mother. Okay? Now, this is a duplicate slide. Now to the questions. What is the best explanation for the patient's abnormal thyroid functions? All right. A, the effect of rapid weight loss on thyroid function. Raise your hand if you think that is the cause. Okay, nobody. B, the effect of semaglutide on thyroid function. Anybody thinks that? C, lab error. Any hands? Okay. D, overt hypothyroidism due to nutritional deficiency. No. Okay. Then E, subclinical hypothyroidism due to Hashimoto's. Several hands. Okay. And yes, that is the correct answer. Answer E, it is a subclinical hypothyroidism due to Hashimoto's. Now, why is A and D not the right answers? And I say A and D, I lump them together because there is like the theory or the idea behind both of those distractors is the same, which is maybe the person is not getting enough of either the nutrients that are needed to manufacture thyroid hormone, most importantly, iodine. That is very, very rare to happen, especially in the United States or Western Europe, because it is a iodine-replete society. Iodine is supplemented in almost anything. You have iodine in bread. You have iodine in everything that you consume. So it is very unlikely that you would have a deficiency in iodine, especially in a city or a place where it's not rural area. So it's very unlikely. Now, what about answer B? And I need to explain the relationship of GLP-1 to the thyroid. GLP-1, there is a lot of talk about correlation between GLP-1 and the thyroid. A lot of patients and doctors get concerned about prescribing GLP-1 in somebody with thyroid issues. So here's what happened, is that when they tested the GLP-1 agonists in rats, some of those rats developed medullary thyroid cancer. Turns out that the rats have receptor for the GLP-1 on their thyroid. Humans normally do not have a GLP-1 receptor on their thyroid. The only exception is if there is a mutation that causes them to develop the GLP-1 receptor on their thyroid, such as what happens MEN syndrome, or in familial medullary thyroid cancer, or having a mutation of causing medullary thyroid cancer. Medullary thyroid cancer is one of 4 types of thyroid cancer. It is rare. It is about 5% or less of all cases of thyroid cancer. So, that's an important distinction to know and to make. If somebody has medullary thyroid cancer or family history of it, or like a MEN syndrome, it is contraindicated to give GLP-1 agonist, but patients with Hashimoto's or other things of that nature, that is not a problem at all to give. All right, so number C, lab error not likely. Why not likely? Because TSH is very sensitive, especially the newer generations of TSH, 3rd generation of TSH is extremely accurate and specific. Now, it doesn't mean to not repeat the lab. Of course, we need to repeat the lab, just not because it's a lab error, just you want to see what happens to the trajectory of the lab. Is it going to be completely normal or come back down with time, which sometimes happens when somebody has recovery from subacute thyroiditis, some very specific situations. And you want to confirm, of course, that they got the right patient with the lab draw, although unlikely to be a problem, but you just want to check again to make sure before you commit the patient to treatment. Okay. And the right answer is subclinical hypothyroidism due to Hashimoto's thyroiditis. So we know what is Hashimoto's thyroiditis, but what is subclinical hypothyroidism? We'll find out more about that, but let me first ask you a question about the next step in treatment. Okay, so A, order thyroglobulin antibody and reverse T3. Who thinks that's the right answer? B, start the patient on levothyroxine treatment, 25 mcg per day for 2 weeks, then 50 mcg per day. Who thinks that's the right answer? Okay, no one. Start the patient on levothyroxine treatment, 100 mcg per day. Who thinks that's the right answer? Well, so far we don't have any hands raised. So you have 2 more. Okay, so start the patient on liothyronine treatment, 25 mcg per day. Any hands? And E, start the patient on selenium and iodine treatment. Oh, well, nobody raised their hands in any of those answers. I don't know. Okay, all right, so the questions will become a little bit more sophisticated as we go by. Don't feel bad about that, but it's a chance to learn more about the thyroid. Okay, so the right answer is answer B, which we did, which I started the patient on the thyroid hormone 25 mcg and increased it to 50. By the way, if you didn't see that on the top of the previous slide, his repeat TSH was also elevated, was 7.1. Same thing with the free T4, which was normal. And we'll talk more if you want. Yes, sir. Can you write it down, the question you have, and just like ask me in the question answer? I'll do my best to leave time for questions, okay? So why we didn't do number C, levothyroxine 100 mcg per day. It's because it's too much. It's a big dose to start the patient on 100 mcg. One of the things that actually a lot of times you might not be aware of is that the patient might not realize that they have symptoms. Because the symptoms of the hypothyroidism, especially subclinical hypothyroidism, happen subtle and gradual, so the patient may kind of adapt to it. Sometimes they tell themselves, okay, I'm just getting older, time is going by, I'm just getting older. And a lot of times you ask them, okay, well, how do you feel? They will say, okay, normal, fine, They have no frame of reference and think that just like maybe if they are tired, I'm getting older, I'm slowing down. And a lot of times in retrospect, once they start a treatment, they realize, okay, I'm now thinking better, I'm more focused, I'm more, energetic and so on. But if somebody has a chronic situation with subclinical hypothyroidism and you start on a full dose of levothyroxine, 100 mcg, they will not feel good. They will have palpitations, shakiness, nervousness. So you have to always ease into it and do very gradual increase and titration if you plan on treating with thyroid hormone. Now, the answer C, by the way, with liothyronine 25 is the same, or D is the same as answer C, because the equivalence and potency between liothyronine and levothyroxine is 1:4. So 25 mcg of liothyronine is equal in power to 100 mcg of levothyroxine. So you didn't do the 100 mcg levothyroxine, you shouldn't do the 25 mcg liothyronine. Now, selenium, now let me do the thyroglobulin antibody and reverse T3, which thyroglobulin antibody we agreed is kind of irrelevant in this situation, especially if the patient has already TPO antibody. You had several things that told you that he has Hashimoto's, which is true in his case. It's a moot point to check thyroglobulin antibody. Reverse T3 is a whole different story, is very much hyped in naturopathic circles. It is mostly irrelevant in that case, but if you want, we'll talk more about it in the questions. And the most powerful distractor, because it's partially true, is start the patient on selenium and iodine. Now, so what's true about it? Selenium is a cofactor for thyroid hormone production. So a lot of times where patient is not ready to start on thyroid hormone, and it can be, it's okay. You don't have to start the patient on thyroid hormone in this situation. If you tell them, okay, you have this condition, and they say, but I don't want to take medication, fine. They like, supplements. You can do selenium. The dose is 200 mcg per day. Okay, don't do it indefinitely. It's just a course I explained to the patient, 2 to 3 months. But the problem with this answer is mentioning iodine. Iodine has a complicated relationship with the thyroid. And in Hashimoto's thyroiditis, actually iodine makes people worse, not better, especially with the higher doses that are present on the market. A lot of them have huge amounts of iodine, which will cause the thyroid to actually levels to drop lower rather than improve. So that's why that answer is not correct. But what is subclinical hypothyroidism? This is the curve of the TSH and T4, and what you can see is the TSH is much more sensitive to the changes in thyroid hormone than T4 is. So as you progress from normal thyroid status to hypothyroidism, you get this rise in TSH where for a period of time, the TSH is rising and the free T4 is in the normal range, as you can see. That is what we call subclinical hypothyroidism, the situation with an increase in TSH, normal T4. It is a wrong name. It is a misnomer. I want you to know that, because subclinical hypothyroidism implies that, well, subclinical, no symptoms. Patient doesn't have any symptoms. But that's not true. A lot of times with subclinical hypothyroidism, you do have symptoms. but it is the name that stuck, so I guess we'll stick with it, right? Then after the TSH goes to a certain point, and by the way, that point is really relatively high, like it might need to go to 20 or more for the TSH to rise above 20 when the free T4 starts to drop below the normal range in cases of primary hypothyroidism. So these are some important things to consider for the subclinical hypothyroidism, and that's definitely where the patient is. And the distribution of the TSH in patients with obesity, overweight, metabolic syndrome, there is a bigger tail of the TSH. Now, if you see those two curves, the free T4 is the normal bell-shaped curve. That's true for every patient, that they have a bell-shaped distribution of the T4. Not so with the TSH. The TSH tends to have what we call a positive skewing, where there is a range, but there is a lot of people who would be considered normal on the tail end of the range. If you have like the most of the patients have a TSH between 1 and 2, for example, you have some that have 3, some that have 3.5, and so forth, and are considered normal or in the normal range. That process is even more in patients with metabolic syndrome and obesity, and it doesn't mean that they have hypothyroidism, and it doesn't mean that thyroid hormone is what's going to fix the issue for them. As you notice from this case, one of the reasons I told you I picked that case is because the patient lost 100 pounds, all the while having hypothyroidism, all the while having the TSH increase, right? So that subclinical hypothyroidism didn't prevent him from losing 100 pounds with the right nutrition, physical activity, and medication, right? Okay, so why treat subclinical hypothyroidism in the first place? Well, one of the reasons is the effect on cholesterol and the effect on the cardiovascular risk factors and the effect on symptoms. Now, this is just one study that shows you that there is some increase that happens in triglycerides, total cholesterol, and LDL, and not in this particular study, but in other studies, there is an increase in those lipid markers with subclinical hypothyroidism, to the extent that with an increase of the TSH up to 25, like just the subclinical range, with the free T4 being low, there is up to a 10% increase in total cholesterol and LDL. But once you get into overt hypothyroidism with high TSH and low free T4, the increase in LDL and total cholesterol is 40%, which is a huge increase. And it's important to know so that when you see a patient with both with a hypothyroidism and with a high cholesterol, you would not start with the statin. You would start with treating the thyroid, because a lot of times the picture will be completely different. Patient cholesterol panel will be completely improved after you start the thyroid hormone, and when their thyroid hormone levels are normalized. Moreover, if you do the statin first, they are more likely to get myalgia, because hypothyroidism will predispose them to the myalgias and side effects of the statin. Okay, another thing that happens with subclinical hypothyroidism is diastolic hypertension. Typically diastolic, the lower number goes up. Another thing that happens is accelerated atherogenesis. There is a study that showed that the carotid intimal medial thickness, which correlates with future cardiovascular events, was increased in patients who have subclinical hypothyroidism with a TSH above 7 or 8. That is important. So, of course, for those reasons, not to mention the symptoms that can be subtle, we many times have to treat subclinical hypothyroidism. All right, so what happened in this case is that we did give him the medication, he did respond to it, and sure enough, in retrospect, he says, yes, my my cognitive function is better, my focus concentration. Remember, he's in IT. He needs his focus concentration all the time. And he did feel better. He lost an additional 15 pounds with that. Okay. How are we doing on time? What's time now? I cannot see it from here.
It's about 15 minutes.
Okay, well, okay. Yeah. We have several other cases. I'll go through the case 3 very quickly so that just you have it, and then we'll leave time for questions. Okay, case 3. So this is a patient seen in 2022. MS is a 24-year-old female patient seen as a new patient visit for evaluation management of hypothyroidism. She had Graves' disease in 2014. Thank you for telling me. She had hypothyroidism status post-thyroidectomy. So basically had Graves' disease, had thyroid surgery, removed the thyroid, and developed hypothyroidism and hypoparathyroidism. And then the problem was her dose was fluctuating too much. She couldn't get consistent thyroid levels. At the time she saw me, she was on 150 levothyroxine and liothyronine 5. You don't have to read everything. I'm just going to give you the most important points. And her main complaint was numbness of the hands. Okay, so the question for you is, well, in deciding her thyroid hormone regimen, all the following factors are important to consider except. So what's the except? Which one is not as important to consider? So A, relative potency of T4 and T3. Who thinks this is right? Let me put it this way. Who thinks that this is an important thing to consider? Yes. Yeah, the hands that were up are correct. It is. How about the body weight and weight change? Yes, it is important. Okay, how about interference with absorption of the thyroid hormone by other medications and supplements? Yes, extremely important. How about brand versus generic, Synthroid and Cytomel? Is it how important it is relatively to the other things? Well, yeah, it's not as important as the other things, honestly, and I'll explain why in a second. And last thing is date of the last time the thyroid hormone was adjusted. Is that important? Yes, it is. Okay. And the one thing that is not as important is the brand versus generic. Why? Because basically there are several things that determine what full dose replacement of thyroid hormone is needed by the patient. Full dose replacement is somebody who doesn't have thyroid gland. Either they had the thyroid removed by surgery, or they have a non-functional thyroid gland. They had such a long history of Hashimoto that their thyroid is not working at all. In that case, the doses that you would give for adult females would be 1.6 microgram per kilogram body weight per day. Males less, 1.4 micrograms per kilogram body weight per day. And when somebody is above the age of 65, you just take that down 0.2. So for women, 1.4, for men, 1.2. Okay, so that is with using T4, using levothyroxine. Different thyroid hormones have different potency. So Synthroid or levothyroxine is T4, but liothyronine, which is T3, has a different higher potency. 5 micrograms is about equal to either 20 or 25 of micrograms of the thyroid hormone, of the levothyroxine. If you have a natural, so-called natural thyroid product, which is basically an extract of the thyroid glands of pigs and cattle, purified and made in a tablet form, Armor, NP thyroid, so forth, those are made of T3 and T4. And the reason that a lot of patients prefer them is because they get a kick out of that medication, because it is highly rich in T3. So in pigs and cattle, unlike humans, they produce about 50% of what they make is T3. So when patients take the Armour or NP, they feel that boost, that initial kick. And it goes on a different dosing schedule. So even though T4, T3 are in micrograms, Armour and NP are in milligrams. So it's a different thing altogether. 60 milligrams of Armour or NP is about equivalent to 88 micrograms of Synthroid or T4. Okay, one slide here that shows you that all the T4 preparations are color-coded. All of them have the same color code, meaning that if you get like a white pill, that is going to be the 50 micrograms of anything, of levothyroxine, of the Synthroid, brand name Synthroid, of Levoxyl, of whatever T4 preparation. And they use that for kind of identification purposes, and it has some importance that we'll talk about if you want to ask the questions. But again, the difference between brand and Synthroid is overrated, and nobody has also that idea about, or that concern about the brand versus generic in cases of liothyronine. Now, if a patient has been on brand name Synthroid, and they feel strongly about continuing on brand name Synthroid, you should be prescribing them brand name Synthroid. Okay, it is a little bit more consistent. Difference between it and the generic is basically in quality control. It is more consistent dose to dose and does not deteriorate as fast as the levothyroxine if it is left beyond 3 months or 4 months. It doesn't drop in the amount that it contains more as much as the levothyroxine does. But if cost becomes like a prohibitive issue, it is okay to use the generic form, and there's more information about that in the handouts I sent you. So what ended up happening with case number 3 is that the thyroid hormone levels stabilized on that combination that I put her down to 125 mcg with 5 mcg of liothyronine, but because that was the right dose for her based on the body weight. But we made sure that she absorbs the thyroid hormone in the right way. One of the things that was happening is she was taking calcium too close to the thyroid hormone. It is a common mistake, especially in somebody who had hypoparathyroidism, so she needs to be on calcium, and it interferes with the absorption of thyroid hormone. In fact, calcium, iron, and vitamins are so powerful in their blocking the absorption that they have to be within 2 hours of the Synthroid, or more than 2 hours, because basically if you get it any closer, you can risk that interference, and if taken together, they can cut back on the absorption of thyroid hormone by up to 40%. So, and we treated the presenting symptom. In her case, the numbness was actually hypoparathyroidism, hypocalcemia, which responded to calcitriol prescription. Okay, I'm going to stop here because I know we need time for questions. So I'll just stop here and
Sherif, the biggest question people have is about reverse T3.
Oh, all right, yes. And I didn't forget you. I will come to your question. Okay, so what is the reverse T3? Like, remember what I told you about the T4, which is that protein body with 4 molecules of iodine. To activate it, you have to remove, there is an enzyme called 5-mono-deiodinase enzyme, removes one of the molecules of iodine in a certain position to make it an active thyroid hormone called the T3, the actual T3. Now, if there is a monodeiodinase, there is another monodeiodinase which is called just 5-monodeiodinase without the dash. It removes one molecule of the iodine but in a different position, making that reverse T3. So it is T3 but with that iodine removed in one position rather than the other, resulting in that T3 being inactive. So it is a way of inactivating the T4 by converting it to reverse T3. Now, it is gained popularity in naturopathic circles who feel that they need some ammunition of some sort to give the armor thyroid. Like they check the reverse T3, if they find it to be elevated, they will say, oh, you see here, this is more evidence that you need armor thyroid. Now, my opinion, what you should do, if the patient is so inclined, check it. It's okay. Check the reverse T3. I only had one time a problem when I checked it because the patient's insurance was considered to be experimental, all of that, and it was very hard to convince them. It was a nightmare. But most times nowadays, insurances do not balk at that. You can check it. Most likely it will come back normal. It's just you're setting the patient's mind at ease, and it doesn't change the decision of your treatment. Just accommodate the patient. It's okay to check it, all right? Even though you and I know that it's not really playing a major or any role in treatment, it has some applications that don't have to do with hypothyroidism whatsoever. They have to do with another condition called euthyroid 6 syndrome, different story. But if patients believe strongly that you are a bad doctor unless you order this test, for heaven's sake, order it. Okay?
Who was the person that had the question previously?
So on case 2, Sherif, so if you have a patient with TPO antibodies that are positive, is there a level of TSH you're looking for if the T4 is still normal, if a patient isn't having overt symptoms that you're generally starting on, or is it more based off the feel of the individual patient?
Thank you. That's a very important question. So there is no one size fit all. The decision of where you decide that this patient has subclinical hypothyroidism and needs treatment depends on multiple factors. One of the most important ones is their age. So a TSH of 5, for example, in a 30-year-old is completely different from a TSH of 5 in an 80-year-old. There is a natural gradual rise of TSH with time, with age. And to the point that they used to say that what's the upper limit of TSH? It's the decades of patient's life. So if somebody is in their 80s, it's okay for them to have TSH up to 8. If they're in 70s, it's okay to have it up to 7. Now, maybe that's a rough and crude way of estimating it, but it just gives you an idea that if somebody is young and their TSH is 5 or increased, that I take that with, like, I want to be much more proactive with that and start them on thyroid hormone versus somebody who is older. And I know that the people get tricked with this inadvertently, patients and doctors, like, because they see that number, red. EPIC has, like, anything outside of the normal rate, bright red blood color, and so people get so bent out of shape about, okay, my TSH, and I keep on telling them, if somebody is 70 or 80, please, you don't need thyroid hormone. As a matter of fact, there is evidence that if you start somebody older in 70s or 80s on thyroid hormone for a TSH mildly increased like that, actually you make them die more. There is increased mortality. You can precipitate atrial fibrillation. You can precipitate cardiovascular death. You don't want to mess with that. So, but younger, absolutely, especially if they have symptoms, and also they have longer duration before they develop overt hypothyroidism.